Good afternoon. Welcome to the Department of Medicine Grand Rounds. My name is Sam Wood. I'm one of the internal medicine chief residents. Thank you all for joining us today, both in person and online. Next week's Grand Rounds is going to be the Clinical Pathological Conference, CPC, and it's going to be given by Dr. Peter Darwin. Today's Medical Grand Rounds is our quarterly Grand Rounds from ICTR, the Institute for Clinical and Translational Research. It's titled Diagnosis of Viral Community-Acquired Pneumonia and will be presented by Dr. Jonathan Baghdadi. Dr. Baghdadi is an infectious disease physician and hospital epidemiologist at University of Maryland Medical Center at both the downtown and midtown campuses. He's an assistant professor in the Department of Epidemiology and Public Health and the Department of Medicine, and an investigator at the Center for Innovation in Diagnosis. He received his MD at NYU School of Medicine and his PhD in Health Policy and Management at the UCLA Fielding School of Public Health. He chairs the Infection Prevention Committee and Sepsis Working Group at Midtown Campus and serves on the UMMS Sepsis Steering Group. His research background is in health services, and his interests involve quality measurement in early sepsis care and implementation of molecular diagnostics for infectious diseases. We're excited to hear from him today. Please join me in welcoming Dr. Baghdadi.
All right, thanks, Sam. Is everyone able to hear me all right? So once again, my name is John Baghdadi. I'm an assistant professor in epidemiology and public health and medicine. And today I'll be telling you about work that we've been doing to design a diagnostic pathway to improve antibiotic use for community-acquired pneumonia. I've got no financial conflicts to disclose. This work that I'll present to you today is currently funded by an ARC K08 and a contract with the CDC. Previously, we've had funding from the University of Maryland, Baltimore ICTR KL2 program, among others. I also wanted to issue a disclaimer before we got started. I'm going to talk to you a lot today about viral pneumonia. This talk is informed by COVID and probably more relevant because of COVID, but is not specific to COVID, and it's not a COVID talk. So, okay, this has become one of my habits when I'm giving a really long talk like this, where some of you may get an important tiger message and need to step out, or get hungry or need a bathroom break. So I'm just going to tell you the main points up front. Today, I'll be trying to convince you that unnecessary antibiotic use for suspected respiratory infection is related to issues in diagnosis. And the respiratory virus panel test, which we'll be talking about, has unfulfilled potential that I think we can tap into using a set of methods known as diagnostic stewardship. And then I'll preview for you a pathway we've built into EPIC at the Medical Center in Midtown to try to improve both diagnosis and antibiotic use for community-acquired pneumonia. To help us sort of orient ourselves, I think it's helpful to start with a case. Yeah, no problem. So it's helpful to start by thinking about a case in a smaller format. This could have been interactive, but in a grand rounds, you're probably just gonna have to think about it to yourself. But put yourself into the mindset of the clinician and sort of what you would do. So the case that I'll present to you up front is a 50-year-old man who comes into the ED with upper respiratory symptoms, including sore throat and cough. He's febrile, but exam is otherwise normal. Chest x-ray is read as being abnormal, consider infection. And then someone orders a respiratory PCR, which is positive for rhinovirus, which you as an astute clinician know is a cause of the common cold. So the first question is, in this case, did the respiratory virus panel test lead to a diagnosis? Maybe based on history and symptoms, you already thought this patient had a viral infection and the test confirmed that. But what if the test were negative? Could this patient still have a viral infection? Is it maybe less likely? And then contrast that case with this one, where you have a 50-year-old man with a very similar presentation, only this time, for some reason, maybe he had an abnormal lab value in the computer. You're not really sure. For some reason, this patient was started on antibiotics and admitted to medicine. The rest of the case is the same, febrile, but the rest of the exam is normal. Chest x-ray is kind of ambiguous, and the respiratory PCR is positive again for rhinovirus. Question I have is testing more useful this time? Maybe now it would lead you to reconsider that antibiotic prescription. And what about if the test is negative? Does that mean the patient, does it reinforce the need for antibiotics? Does that mean the patient, is more likely to have a bacterial infection? These are the sorts of things we are thinking about in this project. The reason why I'm talking to you about this today is that respiratory syndromes and lower respiratory tract infection in particular are the most common reason why antibiotics are prescribed in the hospital. This is a point prevalence study of over 4,000 patients from 180 hospitals across the US. And in 35% of cases, the listed indication for antibiotics was pneumonia. At the same time, we probably overdiagnosed pneumonia. These are data from the Michigan Hospital Medicine Safety Consortium, where they're developing an e-measure related to this. In order to count for the purpose of this chart as an overdiagnosis, you need to be on treatment with antibiotics for pneumonia, but not have at least 2 signs or symptoms, things like cough and fever, or have negative imaging findings. And so what you can see across the board is that between 10 and 15% of the people in patients who are being treated with antibiotics for pneumonia lack signs, symptoms, or imaging findings. And I've been told that it's impossible to miss on this chart that the number is going down over time. That's because of specific QI efforts that they're working on related to diagnosis of pneumonia within this health system. Misdiagnosis is likely even more common in the emergency department. So this is a study that was done a few years ago, patients who were started on antibiotics in the ED for suspected CAP. What they did was, as soon as you were started on antibiotics, they made the decision for you, regardless of what imaging you were planning to get, they were going to run a chest CT. Then after the patient was discharged, they convened an expert panel to review the chart for signs, symptoms, chest imaging findings to determine if the treatment for CAP was appropriate. What they found was that among the patients who are treated for community-acquired pneumonia with antibiotics, 38% clearly did not have pneumonia, and another 11% maybe possibly had pneumonia. So somewhere between 30 and 50% of the people who are started on antibiotics in the ED for this syndrome probably don't have it. Even among those who have a true infection or a true pneumonia, not all of those cases will be bacterial. So this is the EPIC study that was run back in 2015, where they took all patients, over 2,000 patients who presented to 5 hospitals in the Midwest and South. They ran every microbiologic test that was available to them at that time. And only in 38% of the cases was an infectious pathogen able to be identified, and more than half of those were viral. So in fewer than 15% of cases of true clinical pneumonia, were they able to isolate bacteria. And so that's why I'm suggesting to you that we probably use too many antibiotics for pneumonia, and it's because of issues related to diagnosis, where antibiotics for pneumonia are common, often given in the absence of signs, symptoms, or chest imaging findings. And then even among patients who have a true infection, many of them are probably not going to be benefiting from antibiotics because they don't have a bacterial cause of disease. All right, so I just hit you with a lot. And so I've just put into this talk a few breaks, mainly for myself. Before I worked at the University of Maryland, I was living in LA for a while. This is a bowl of ramen that looks like a bowl of ramen I would have eaten at Sujita Annex, which was my favorite place. They have an option at Sujita for you to add extra fat to the ramen, which sounds gross, but it isn't. All right, so the next question is, how can we reduce antibiotic use for patients with suspected respiratory infection? The work that our team is doing is trying to leverage molecular diagnostics. So specifically, we're working with the respiratory virus panel test to see if early recognition of viral disease or viral infection can discourage antibiotic use. Many of you are probably familiar with these tests from using them in clinical care, but a quick primer. These tests use multiplex PCR. They're molecular tests looking for genetic material from different types of pathogens. When we're talking about the sensitivity and specificity for each pathogen that it's trying to detect, they're both very high, highly accurate tests. They run rapidly, so within an hour or two after the specimen hits the lab, as long as there's a tech available to run it, they're not waiting to batch a specimen. Over the last 10 years, more and more medical centers have been adopting these in clinical use, but adoption likely exploded during COVID because many medical centers, including our own, bought more of these platforms as a way to get access to rapid COVID testing early on. And the specific panel that we're using is the BioFire Film Array Respiratory Panel 2.1. I show you this slide, which sort of compares different panels that are available on the market, mainly to show you that they have a lot of overlap, but also have sort of small idiosyncratic differences. And I've highlighted the one that we're using here at the medical center. The other thing that I think is sort of interesting about this slide is that if you're reading a review on this topic, or if you go to BioFire's website, you'll see the pathogens listed in this way, where they're put in alphabetical order. There's no priority given to what we think is important or what's not important. The main purpose of a slide like this is to show you breadth, to say, look at all the different things this test is evaluating your patient for. But in reality, they're probably not all of equal weight, right? And so there are different ways that you can sort of stratify this based on importance. And the way that I'm thinking about it right now is in terms of whether they have implications for management of your patient, either direct or indirect implications. And so on the far left of this slide, I've listed the pathogens that we think have direct implications for patient management. These are ones where, regardless of what's happening for your patient, if you diagnose them with COVID or flu, you're going to at the very least consider direct-acting antivirals. On the right of those are the bacteria that are available on the panel. Likewise, if you diagnose one of these, you're going to start antibiotics for that infection. The sort of issue, or the reason I downgrade the bacteria is because they're just not all that common. So I know in medical school, I was taught that a common cause of walking or atypical community-acquired pneumonia are these atypicals like Chlamydophila or Mycoplasma. But the truth is, I've reviewed something like 15,000 tests run at the medical center over a 5-year period, and they appeared in 6 specimens. They're just not there. To the right of those are the viruses, which tend to be more important for severely immunocompromised hosts, like adenovirus, parainfluenza, and RSV. RSV, of course, also very important in kids. These are viruses that have antiviral treatments available, but they're highly toxic, so we only think about them in severe or life-threatening disease. Of course, you may be adjusting immunosuppression if you diagnose one of these. And on the far right, we have the less important pathogens, things like seasonal coronavirus and rhinovirus, which I've put in large font because by far it's the one that comes up most commonly when we run this test. And these are ones where I'm not really thinking about treating the infection. I'm thinking about what can I stop now that I've recognized it's there. And then so the next question is, okay, this test is great. It has a lot of appealing features, but what do the studies show? And in multiple clinical trials, both randomized and quasi-experimental trials, when we implement testing broadly for, let's say, all patients who are coming into the ED with cough, it does not appear to push the needle on overall antibiotic use. And there's a lot of potential explanations for why that might be the case. The one that I kind of believe is that clinicians will make the prescribing decision before the test results become available, even if it's a point of care test. That 15-minute lag is very awkward, where I'm going to decide to start antibiotics, decide to order the test, and then 15 minutes later, I get a sort of a contradictory result, and I have to, go back and cancel my order? It's just awkward. Once the patient gets admitted to the floor, then diagnostic inertia sets in, where maybe now the patient's a little better. Did they get better because they're on an antibiotic? Or maybe they're worse, and then they really need the antibiotic. But in all of these studies, you can sort of pull out subgroups, post hoc subgroup analyses, where maybe there are subsets of patients where if we selected who is getting tested better, you could see an impact from testing. And so that brings me to this dichotomy between the way respiratory panels are frequently presented in theory and the way I think about them in practice, where in theory, each subcomponent of this multiplex PCR test is highly sensitive and specific. But in practice, if you're running 22 tests simultaneously over and over and over again, the likelihood of a false result increases exponentially. In theory, false positives due to lab error are rare, but in practice, what I would think of as a clinical false positive or a result that I'm going to ignore because it kind of doesn't fit into what I'm thinking is happening with the patient are not infrequent. In theory, panels can detect many pathogens, including both viral and bacterial pathogens, but in practice, it's basically a rhinovirus and COVID test that's sometimes positive for the flu. In theory, clinicians love using it because it produces a fast result, but in practice, that means that we end up getting over testing. And in theory, early recognition of viral infection should reduce antibiotic use, but that's just not what the studies have shown for one reason or another. So this is a bowl of ramen from Daikokuya, which is across the street from Sujita, and people like it because it's open late, and they say it's as good as Sujita, but it's not. All right. So the premise of this research is that respiratory virus panels are often used in situations where maybe they're not going to be helpful. And we're going to try to use diagnostic stewardship to address that gap, to match the test to the opportunity for usefulness. And so that raises a question, which is what's diagnostic stewardship? So, all right, so diagnostic stewardship is an area of emerging or increasing interest within the infectious disease professional societies. This is a position paper that was released by the Society for Healthcare Epidemiology of America earlier this year. And the sort of tagline or like basic summary is that diagnostic stewardship is trying to match the right test to the right patient at the right time to lead to the right action. This is a conceptual model for diagnosis that I pulled from a report by the National Academy of Medicine that was released a few years ago. I'm showing this mainly to try to convince you that diagnosis is complicated. You can see that in this model, they start all the way at the left from the patient's own personal experience of disease to the right on health outcomes. And in this vast diagram, diagnostic testing is just like one spoke in the wheel. It's a subpart of a subpart of a subpart. But in actuality, diagnostic testing is a complicated process in and of itself, where the clinician experience of diagnostic testing is, I'm going to put an order into the computer, and then some period of time later, the result is going to pop up in my face, and I can interpret it and use it to guide patient care. But actually, there are many steps, where once I place that order, someone then needs to go and collect that specimen. It needs to be sent to the lab, processed, and then the results are structured in a way to deliver the most useful information so that it can be actionable to the physician. And each one of those steps presents an opportunity for intervention where I can improve or modify processes to make testing better, to make testing more useful. And each of these interventions is a sort of example of diagnostic stewardship. The classic example I think of for diagnostic stewardship is if you tried to order a C. difficile PCR on a solid or form stool. In order to have C. diff infection, you need to have diarrhea. If you send form stool to the lab, they're going to reject it. They're going to say, try again. And that's, basic diagnostic stewardship. The other comment I'll make is that diagnostic stewardship works slightly upstream or in parallel with antimicrobial stewardship, where the point of diagnostic stewardship is to lead to better or more useful testing. And then on the back end, after the results become available, antimicrobial stewardship can step in to guide antibiotic use and selection. This is a bowl of ramen from Killer Noodle, which opened not too long before I left LA. I included here because they had some interesting options on the menu. I hadn't had ground beef and ramen before. I would probably go back. All right, so that's all the background. Now I'll tell you about the work that we're doing. This is a framework that I came across a little bit after this project started, but it fits kind of the approach that we've taken. These are supposed to be the steps that you go through when you're designing something new. You don't have to follow this in order, but we just so happen to have. And so we're trying to design an intervention that's going to improve antibiotic use for respiratory infections by improving use of that respiratory virus panel test. The first thing we wanted to do was to understand why clinicians test. And to do that, we ran a survey of experts among the SHE Research Network. And I don't know if I should be stopping when I see that someone has put something into the chat, or if you guys just want to tell me, okay, cool. So in this survey of experts through SHE, the first thing they told us consistently, predominantly across the board, is that they think respiratory virus panel testing supports diagnosis and patient care, and they frequently told us that they believe that it can support antibiotic de-escalation in appropriate situations. But they were much more mixed about whether a respiratory virus panel test can actually improve the patient's health outcome, and I believe this ambiguity or ambivalence probably reflects the lack of impact in clinical studies. We also asked them for their opinion. They gave us free text on how best to use these tests, and they gave us a lot of sort of pearls. One such comment would be that no one cares about anything besides flu and COVID when they order this respiratory panel. Another one, which was sort of a lightning moment for me, is that this is not really a test for a patient you believe has bacterial pneumonia. If you've already decided your patient has bacterial pneumonia, you're going to treat them with antibiotics regardless of what the results of this test are. And then someone cited the potential harm from over-testing, which I think is super interesting, where if I test a patient and it's negative, does that mean they now need antibiotics because it's not viral? So, all right, so we tried to get into the heads of why people are ordering the test. The next thing was to explore real-world testing data using the electronic health record from the medical center. So we ran machine learning techniques with EHR data from the medical center to identify when testing is useful. The sample was adult patients who were receiving gram-negative antibiotics who also underwent respiratory virus panel testing at UMMC or Midtown over a 5-year period. We only included the first respiratory panel from their admission. And we created this outcome, which was useful testing, which we defined as detection of a viral pathogen, meaning a viral diagnosis, that was associated with de-escalation of antibiotics, de-escalation as in either stopping or narrowing. And the statistical technique we use, the machine learning technique we use is called lasso, where you can throw a bunch of variables into a model and it's going to pull out the ones that it thinks are most important. We then took those variables from lasso and put them back into a standard multivariable logistic regression. Here I've ranked them, where at the top you can see variables that are associated with increased likelihood of viral diagnosis and antibiotic de-escalation, and at the bottom variables that are associated with decreased likelihood of useful testing. And the takeaway here is that testing tends to be more useful if the patient has sort of a pneumonia syndrome. At least there was some initial concern when they were admitted about pneumonia, and testing is less useful for people who are really sick. At the bottom of this chart, I see patients who are in the ICU, patients who are in shock, patients who are in respiratory failure, or have hematologic malignancy. Those are patients where even if you diagnose a viral pathogen, which may be less likely, people are probably going to continue antibiotics. We also ran a CART analysis. CART is classification and regression tree, and the goal of this was to try to pull a subgroup where we think testing is the most useful. If you could find that ideal subgroup for patients where we think testing is really high yield. And the results are surprisingly simple. So testing is about twice as likely to be associated with a viral diagnosis and antibiotic de-escalation if it's performed in the first 40 hours of hospitalization. In those situations, it's 12%. Probability of being useful versus 6%. So, all right, great. So now we've got qualitative data, we've got quantitative data. This is mixed methods 101. The next step is to integrate, and this is where we wanted to build our intervention. And so I think through this project, there are a number of different innovative things that we've done, but this is the one that makes me the most excited, where I think this is the thing that we're recommending or working on that I think is the most likely to change practice or change the way people think about this test, which is currently the way we select patients for respiratory virus panel testing is not perfectly, but kind of backwards, where right now we use respiratory virus panel tests on people who are really sick. We're worried about them, so we want to do more testing. We use it for immunocompromised folks because they could be infected with anything and we want to know. And then we use it kind of without restraint throughout the hospitalization and for any patient who's coming with cough. Whereas actuality, if your goal is, so I recognize that testing has many different goals, but if the goal is just to discourage or reduce unnecessary antibiotic use, the opportunities are probably in those low-risk patients where I'm going to feel more comfortable stopping antibiotics after I find that rhinovirus. Similarly, if I have a patient who is severely immunocompromised for a lung transplant, who comes into the hospital, that detection of a virus may be less likely to make you feel comfortable stopping antibiotics versus an immunocompetent patient. We know from that CART analysis that testing seems to have the highest leverage early in hospitalization. And then what we got from our survey of experts is that in order for there to be sort of a actionability of testing, there needs to be maybe some ambiguity in the diagnosis, where this is someone where we think they might have pneumonia and it could be bacterial, but maybe it's not. And so we put all those things together to design this pathway. And I'll walk you through it. So the pathway starts when a patient comes into the ED with respiratory symptoms. We're limiting it to people who are going to be admitted or who are already admitted. When you try to order a respiratory PCR, the EHR is going to do an assessment of their pre-test probability of bacterial pneumonia. The EHR can then recommend testing that is optimized for their risk level. And then sometime later, maybe the next day, once the results become available, antimicrobial stewardship can step in with guidance on how to respond to those results. And I'll walk through each of these steps. So first, we can talk about the patients that are going to be included. Pathways activated by an order for respiratory PCR. We're trying to include only adults who are going to be admitted because the pathway does include sputum culture, and it's not a good idea to do that on people who are being discharged from the ED. And then we're excluding people who have been hospitalized for more than 3 days, people who've already had a workup and you're sort of trying to revisit what's happening with them, and people who are severely immunocompromised. The EHR assesses the patient's probability next once you try to do that respiratory PCR. And so in order to do that sort of objective assessment of pretest probability, we reviewed the literature to identify clinical predictors of bacterial pneumonia. The truth is, this is still a little rough. Most of the studies that we found were like from the 90s. But we were able to come up with a set of risk factors that appear to correlate before chest imaging is performed with bacterial pneumonia. And we took those and we built them into a diagnosis calculator, which you can access on testingwisely.com, that generates a numerical probability. Now, it turned out what we'd initially hoped was to be able to bring these numerical probabilities directly into our pathway. And EPIC's not quite that sophisticated, but we split it into 3 groups: low, medium, or high. So, okay, so you've placed your order for a test. EPIC has made that assessment of whether their pretest probability of bacterial pneumonia is low, medium, or high. Now it's going to recommend testing. And so there are 3 arms, and the tests that are recommended depend on the purpose of testing in each of those groups, which differs slightly. So in people who are low pretest probability for bacterial pneumonia, the goal of testing, I think, is to identify opportunities for when we can safely stop antibiotics. And so to do that, we're recommending a full respiratory virus panel test and a procalcitonin. Patients who are medium pretest probability of bacterial pneumonia, those are the ones where there's real diagnostic uncertainty. And so I want to cast a wide net, looking for both viral and bacterial pathogens to solidify a diagnosis. We do the full respiratory virus panel test. We also do a sputum gram staining culture. And then finally, in the high probability group, which it turns out is not that common, the goal of testing is primarily to inform optimal antibiotic selection. These are patients where you're probably going to give them antibiotics anyway, so we're going to try and support the most effective and safest antibiotic use possible. And so for that reason, we're doing a focused COVID, flu, RSV PCR in case they're going to benefit from antiviral therapy, and then sputum gram staining culture. And then finally, once the results come back, antimicrobial stewardship can step in patients who have results consistent with viral infection. And they're going to be sending both a tiger message and dropping a note in the chart. We don't need to belabor this, but I'll highlight a few points for you. This note will document what the patient's calculated risk category was. In this case, it's low. There will be some guidance on what you can do with antibiotics based on that. In this case, because the probability is low, antibiotics may be discontinued. And there'll be a screenshot where someone has run the risk calculation to give you a numerical probability of both their pre and post-test probability for bacterial pneumonia. And so I'll admit, at this point in the project, I thought we were done. We'd done a lot of work. We'd come up with what the intervention was supposed to look like. I thought we'd just send it in an email to somebody, and then 6 weeks later it would appear. But that's not how it works. It turned out actually we ran into a wall, which is the limitations of trying to build something into Epic. We met with a lot of experts on this. And this was the original design based on all of that input. It was a best practice alert, which we were not happy with. And our top priority was to minimize disruption in clinical workflows. We didn't want to create something that people were going to hate. But the truth is, despite our best intentions, there were a number of problems with this original design. And so we started user testing. And we did user testing with clinicians both downtown and at Midtown, MDs, NPs, and PAs. And after each user test, we would revise the design of this thing until it got to be something that people started to kind of like. And so I'll just highlight a few features of that for you here. It's still quite wordy, but hopefully looks organized. So as with that note, it tells you the patient's pre-test risk category. It gives you some hopefully simple guidance on when you might adjust the risk category up or down based on whether you have a suspicion for bacterial pneumonia or whether chest imaging has been performed. It shows you which factors Epic was looking for and whether they were present or absent. And at the bottom, it gives you the choice to set their risk category, and then it tells you what the tests associated with that risk category are. The design of this is actually a little bit innovative in itself. We used a functionality within Epic known as an alternative alert, which is before this only really used for formulary meds. So if you try to order a non-formulary med, we have a formulary equivalent on, then Epic will say, would you mind subbing in the formulary? We use this instead to substitute in recommended or protocol-based testing instead of the test that you ordered. And we're currently working on vetting all of the exclusions to make sure that it doesn't fire in inappropriate situations. I also would just want to echo that we did weeks and weeks of user testing with this thing, and we heard you, and we know that clinicians hate pop-ups. But what you also told us is that alerts are less bothersome when they deliver useful information or are clinically relevant or add value at the point of care. And so the design is almost finalized, and the next step is just going to be to turn it on and evaluate its impact. This intervention is going live at a hospital near you this summer. Once again, I really want you to try to keep in mind when this alert pops up in your face that the goal is to try to match the right test to the right patient, and we're not trying to block you from testing. And frequently, if you order a respiratory virus panel, the thing is just going to tell you that you're going to get a respiratory virus panel. It's just subbing in what the protocol recommends for what the initial order was. And I would encourage you, when the alert appears, to consider what your pre-test suspicion for bacterial pneumonia is, and then you can select the appropriate category. Ultimately, the Epic's not going to force you to do anything. The clinician remains in power. And the outcomes we're looking at are antibiotic use, but also measures of safety. So just to bring it all back to that case, that second case, the person who is started on antibiotics and admitted to medicine with a potential upper respiratory infection, our intervention would have categorized this patient as being low risk. They would have gotten a respiratory virus panel and procalcitonin. In this case, it's positive for rhinovirus, so the inpatient team would have gotten a Tiger message the next day suggesting they might consider stopping antibiotics. And that's it. That's my talk. We built this. The goal is to improve antibiotic use for respiratory infections. I hope you guys don't mind it. If you feel like it causes problems for you clinically, please feel free to email me directly, because the point of this is to have it work within or be compatible with your workflow. And the goal is by supporting diagnosis of viral CAP in low-risk patients, we can reduce unnecessary antibiotic use. I'd also like to acknowledge all the people who contributed to this project, including Dr. Davis and the ICTR, who are really the first ones to fund this through the KL2 program. So I can open it up now to questions. Yeah, it's good. Um, and Oh, no, that's good. I wasn't expecting to get a question from an ID fellow about sputum gram stain culture. But so the guidelines for management of CAP don't recommend using sputum culture for all patients who present. It's like you can select based on clinical intuition about when it's going to be useful. But we communicated with the stewardship program about this, and the idea is if your patient is being admitted and they're starting on antibiotics, then collecting that culture up front, maybe a little earlier than we might usually think about collecting it, creates an opportunity 2 or 3 days later to de-escalate or to optimize antibiotic use if we identify a susceptible pathogen. So if the patient is already coming in and already going to be on antibiotics for pneumonia, it's hard to imagine a downside from sputum gram stain culture. And actually, I'm trying to remember who gave me this feedback throughout this project that some people believe that sputum gram stain is probably the most useful test if you're thinking about whether your patient has a bacterial cap or not. It comes back very quickly and has predicted value. Yeah, no, that's a great question. So that's definitely sort of the two different subsets of patients who get the respiratory virus panel at our medical center anyway are the community folks who have some kind of a community-acquired illness, and there's a large volume of these that are performed through bronchs, and like sometimes multiple respiratory virus panel tests will be performed on bronchs, like one from the left lung and one from the right lung simultaneously. And I think honestly, I would encourage in that case probably just to dismiss the alert. We wanted to make sure that if your patient came in and you were ordering a respiratory PCR as part of the initial workup, that we were able to be involved at that point. But I think for a patient who's getting bronched, more likely it's going to be revisiting a diagnosis or following up on a diagnosis. In that case, the alert's not going to fire anyway because they already had a respiratory virus panel ordered earlier. But if it's specifically a component of a bronch and subbing in other tests is just going to end up getting sort of sputum cultures duplicated or something like that, it's better to dismiss. Oh. Yeah, I see the question from Dr. Hochberg about use of the algorithm or the pathway in the outpatient setting. I tend to focus on inpatient antibiotic use because it feels to me more manageable, more measurable, and less complicated. But I know that there's a tip of an iceberg situation there where as much as we use antibiotics inpatient, there's likely, the beneath sea level, there's a large burden of outpatient antimicrobial use. And actually, I think at the VA, they've done some of the best work to decrease antibiotic use for what they call ARIs. But we would need to customize it for outpatient because, for instance, I would not want to recommend sputum culture routinely on outpatients in certain risk categories. And I have not thought through all those details. All right, so for people who can't see the chat, I should have been reading these questions all along, but Dr. Magner is asking about the costs of not treating and whether those informed our calculations. Dr. Magner, I think That's definitely of interest in this project, and one of the reasons we're measuring a various outcomes in this forthcoming intervention study is going to be to ensure safety, and I think that's the way I would interpret what you're getting at is it safe to withhold antibiotics in a low risk patient with a likely viral infection? And most of us, I think, would feel comfortable saying yes. But it turns out that the optimal management of viral cap is not necessarily as straightforward, and it's not something that all clinicians would necessarily agree on. Some people would suggest that even if your patient has viral cap, if they're sick enough, they should be on antibiotics. That's not necessarily the way I practice, but it's an area of ambiguity. And so hopefully that kind of gets to your question, Larry. But if there aren't any other questions, then I'm happy to close it up 12 minutes early.